I would like to welcome now, speaking for the National Kidney Foundation of Utah and Idaho, Dr. Javier Jaramillo Morales. Are you here? There you are. Very good. I'm glad you showed up. Okay, and it says here, start to clap. Okay, very good. Dr. Morales, it's all yours.
Good. Is it working?
Well,
Okay, thank you.
I hope that works.
Yes. Good evening, everybody. My name is Javier Jaramillo Morales. I'm one assistant professor of nephrology at the University of Utah. My talk today is going about hematuria and proteinuria. So I'm originally from Panama in Central America, not from Florida. Multiple times I've been like, you're from Florida? No, it's in Central America. I did my residency in Orlando, in the University of Central Florida. And my fellowship, I did it at Vanderbilt, and my master's in clinical investigation at Vanderbilt as well. My wife is from here, from Utah, so that's my second home now, and my daughter, and we enjoy doing some taekwondo. So I don't have any financial disclosures, and I didn't receive any remuneration from this presentation. So I'm going to talk about hematuria. I know that this is a life intervention topic this year, but hematuria can present in patients that do too much exercise. And also is one of the most common cause of consults. So there are two types of hematuria. The gross hematuria, the one that we can see with the naked eye, and usually the urine is red or brown. It can be, when we talk about hematuria, it's not just blood. It can be myoglobinuria from muscles, or it can be hemoglobinuria when the actual red blood cells break, either in the urine or in the blood vessels. Also, in women, when they are menstruating, they can have some mix of blood with the urine that can confuse. And we already know about the beads that they can color our urine. So the other type of hematuria, the one that we see more frequently, is the microscopic hematuria. So the microscopic hematuria can be found during a urinalysis on UA in dipstick and the spun urine. So the dipstick, they can detect red blood cells, they can detect hemoglobin and myoglobin. And the spun urine, they actually detect the actual red blood cells. So the UA can detect 1 to 2 red blood cells per high power field. It is more sensitive than the spun urine, but it can be false positive. It can be false positive when there is semen there, when the urine is too alkaline, and when there is myoglobin or hemoglobin. So we need to confirm with spun urine. And the spun urine actually detects the RBCs, the red blood cells. So first, we do a dipstick. That's how, the UA is common. We usually don't do microscopic, that's the spun urine. So after we have a positive dipstick, we need to confirm with the spun urine. So the hematuria can come from the kidney itself, either the glomeruli, it can come all the way from the ureters, it can be from beads and other stuff, it can be from the bladder, it can be from the prostate, from the urethra, so it's not just kidney. So just keep that in mind. So we have an etiology, not etiology, but a concept of transient hematuria. So in these cases, there is no other signs or symptoms, and we just repeat the UA in a few days. This could happen after after doing rigorous exercise or during severe caloric restriction, and then you can have some blood in the urine. So just repeat it in a few days. So what special circumstance we see in hematuria? With vigorous exercise, we just wait for 4 to 6 weeks to repeat the UA. When there is acute trauma to the urethra, we repeat it after also 6 weeks. When there is flank pain, that is suggestion of stones, we order a non-contrast CT or an ultrasound if you cannot do a non-contrast CT. UTIs, when there is fever, pyuria, bacteria, so that can come with hematuria. And then we need to do a urine culture, and then we can repeat the UA in a couple of weeks after completion of antibiotics. So other special circumstance is when we see gross hematuria and visible clots in the urine. So we need to be worried about any urological cause, so we should refer to urology. In pregnancy, if a lady is pregnant, we should order an ultrasound to rule out obstruction or urinary stones. In black patients, there is the possibility of sickle cell trait or disease, and that can cause papillary necrosis for hematuria. There is the sterile pyuria with hematuria that can cause, sterile pyuria is white blood cells in the urine. That can cause with, you have tuberculosis, we don't see that frequently here, but I saw that a lot in Latin America. It can come also with NSAIDs, nephropathy, and when we have acute interstitial nephritis. As Dr. Smith mentioned, it can happen with any type of NSAID. It can happen with omeprazole, pantoprazole, or any medication. So let's talk about proteinuria. So proteinuria, normal adults should have minimal amount of protein in the urine, less than 150 milligrams per day. So any type of excretion of albumin in the urine, even minimal, it's an early marker of kidney injury, especially in diabetes, hypertension, or glomerular diseases. And it's a biomarker of cardiovascular disease risk. So this graph just showed that any type of moderate albuminuria increased all-cause mortality is associated with cardiovascular mortality, AKI, and progression of CKD. So there is 4 types of proteinuria. Not all proteinuria comes from the actual glomerulus. It can come from the tubules. We have the concept of overflow proteinuria, and we have the concept of post-renal proteinuria. So the glomerular proteinuria, it's when the actual glomerulus is damaged. As you can, this is a light microscopy of an actual glomerulus. It can happen with any glomerular disease. The most common in the US and the world, diabetes. Can cause damage to the glomerulus, and you can see some proteinuria at the beginning. Then it can be a nephrotic range proteinuria. And usually it's identified by UA, by urine dipstick. So we have tubular proteinuria. That's different than the glomerular proteinuria. We can have that one when we have damage to the interstitium, when people are using NSAIDs, when you have acute interstitial nephritis, and other Sjogren disease, things like that can cause damage to the tubules and interstitium, and you can have some tubular proteinuria. It's not the same than the albuminuria. It is usually negative for this dipstick, but if you do the spun urine and you do the urine protein creatinine ratio, you can see it. So usually when I see a patient, I like to look the UA because I can detect albuminuria, but I like to do the urine protein creatinine ratio as well, because that urine protein creatinine ratio detects other types of protein, not just albumin. And then we have, in this type of proteinuria, we have light change. Like, there are 2 types of light change. If it's polyclonal, that's not injurious to the kidney. The problem is when it's one just clone and can cause, that's coming from multiple myeloma, and that's nephrotoxic to the kidney. That's nephrotoxic. So this is the overflow proteinuria. When we have a multiple myeloma, when we have amyloidosis, but mainly multiple myeloma, and then that can cause damage to the kidneys. Also, it can happen with rhabdomyolysis, with myoglobin, and with free hemoglobin, hemoglobinuria. And the post-renal proteinuria, when there is you can have proteinuria when you have an UTI, you can have a small amount of IgA or immunoglobulins, you can have proteinuria when you have some kidney stones, when you have some tumors also, that also can cause proteinuria. So the amounts of proteinuria. So the amount of proteinuria, as I mentioned, is minimal, less than 150 grams per day. Mainly all the protein that the kidneys, that the glomerulus filters, it's reabsorbed. So we shouldn't see too much proteinuria. So The albumin, that's the first time, the glomerular type of proteinuria, usually is minimal, 4 to 6 milligrams, and it increases with age and body age. Then we have the concept, that's just not called anymore microalbuminuria, it's just moderately increased albuminuria. That's when the albuminuria is from 30 to 300 milligrams per day. And then we have the severe increase in albuminuria, more than 300 milligrams per day. And that was previously known as macroalbuminuria. But any type of albuminuria, even like moderately increased, is associated with cardiovascular risk. So how we detect and how we measure the protein? As I mentioned, UA and the dipsticks, they mainly detect albumin. That's just the color of the dipstick, and it can be false positive with contrast, and we need to wait 24 hours to repeat it to see if there is actual protein there, and with alkaline urine. So dipstick and UA is mainly albumin. Then we have the quantitative measurement, either the 24-hour protein or the urine protein creatinine ratio or urine albumin creatinine ratio. Why do we do that? Because it's prognosis. If we have minimal amount of protein, even a little bit, that's not as bad as having a nephrotic range proteinuria. So it's prognostic. The higher the proteinuria, the worse for the kidney. And also to monitor therapy. If we start SGLT2 inhibitors, or if we start a RAS blockade, we are measuring the amount of protein in the urine to try to see a decrease, so to monitor response. So the 24-hour protein is the gold standard. As I mentioned, the normal value is minimal amount of protein. What is the problem? Patients don't like to do that, and also it can measure incorrectly. So we need to correct with a 24-hour creatinine. So when we do a 24-hour protein, we do 24-hour creatinine to see, to correlate the amount of protein in the urine. So, what is the, now we have the spot urine. What are the limitations? So the limitations are in the spot urine, we also need to correlate with the amount of creatinine in our body. And as we know, creatinine comes from muscle. So some people, especially young people and people that bodybuilders that have too much muscle mass, they excrete more protein. So we need to be careful when we are measuring that spot urine. And also the spot urine can vary during the day. It can vary like we have the concept of orthostatic proteinuria as well. So this is just a graph that shows the correlation between spot urine and 24-hour protein. So what is the suggested approach to quantify the urine? If you see an UA and then you have a dipstick that is positive for protein, then you should quantify that amount of protein, a 24-hour collection. Then after that, if it's accurate, then you can just follow up with urine protein creatinine ratio, with spot urine. So just follow up with that, like in your regular follow-ups, and then if there is any change in the spot, then you need to repeat the 24-hour urine. And usually we get this referral. So if you feel like there is too much changes or any confusion regarding how to correlate with the creatinine, you send the consult and then we take care of that. So we need to rule out transient proteinuria. Especially in young individuals, it's a qualitative test that is no longer positive. So we do the UA, it's positive for proteinuria, then we repeat it, and yeah, that's transient proteinuria, no further evaluation. It can happen when people will have fever, exercise, or UTIs. So we need to rule out orthostatic proteinuria. So when people are upright, they have more protein in the urine. When they are supine, when they are laying down, normal protein in the urine. The mechanism is unclear. Some changes in the sympathetic nervous system, but we don't know, basically. It's a common find in adolescents, and it's a benign condition. And the issue with this orthostatic proteinuria is it can be an early sign of a glomerular disease. So we need to check that frequently in the regular follow-ups. So we have another concept of persistent isolated proteinuria. That happens when there is no other abnormalities. There is no hematuria, there is no low EGFR or increased creatinine, no diabetes, no hypertension. We need to quantify the urine. We check EGFR. We do a UPEP, urine electrophoresis, to rule out multiple myeloma, monoclonal light change, deposit disease. We do an ultrasound to rule out stones or a polycystic kidney disease. And if there is persistent proteinuria, total protein, more than zero, if we talk about 24 hours, more than 500 milligrams per day. If we talk about urine protein creatinine ratio, more than 0.5 per day. And the same for albuminuria. And then if there is persistent isolated proteinuria, you refer to the nephrologist. So nephrotic syndrome, it is not the same than nephrotic range proteinuria. Nephrotic syndromes is a syndrome. It's heavy proteinuria, there is low albumin, low serum albumin, and there is peripheral edema. And usually it's associated with hyperlipidemia, it's associated with thrombotic events. So that's not this. Nephrotic syndrome, it is not the same that a nephrotic range proteinuria. Since this is the lifestyle and interventions in primary care and some specialties, I published this study 2 years ago, was presented at as a poster in ASN 2 years ago. It talks about, I did this study about aerobic exercise and caloric restriction on mitochondrial DNA in patients with moderate to severe chronic disease. So this study was published in the Renal Physiology journal. So CKD, chronic kidney disease, is an inflammatory state. So the mitochondria is the organelle that produces ATP, but the mitochondria has DNA. So basic science research has shown that mitochondrial DNA is associated as an inflammatory marker. So my hypothesis, our hypothesis was that aerobic exercise will reduce the mitochondrial DNA, the circulating mitochondrial DNA in moderate to severe CKD. So we measure the mitochondrial DNA at baseline 2 and 4 months after aerobic exercise and calorie restriction. And we adjust by age, race, sex, all the good stuff. So what this table just showed that there is no significance here. I'm going to explain more about that. But this one just showed like what were the baseline after usual activity and aerobic exercise. The interesting part was that aerobic exercise increased the mitochondrial DNA, but when we combine the group with calorie restriction and exercise, the mitochondrial DNA went like 30%. That was at 2 months. Then at the end of the study, 4 months, again, aerobic exercise increased the mitochondrial DNA by 81%. And if you combine with calorie restriction, to almost 200%. There, we also measure like interleukins, tumor necrosis factor alpha, all the inflammatory markers. We didn't see any association yet. So the conclusion of this study was that aerobic exercise increased this mitochondrial DNA marker of inflammation in patients with CKD. And we need to do more further studies with inflammation and oxidative stress. Why I'm talking about mitochondrial DNA? So recently, not recently, in the last at least 3, 4, 5 years, people are talking about intermittent fasting. They are talking about calorie restriction we know, but intermittent fasting has the main topic. So interestingly, there are not intermittent fasting. There are some studies that associated that with a concept of mitophagy and autophagy, so changes in the mitochondria. We don't have that data in CKD, but my point is that calorie restriction, maybe intermittent fasting, exercise, all of that changed the inflammation that we can see in CKD. So all of these lifestyle interventions may have future benefits. So we need to continue working on that. Thank you so much. Any questions?
Question?
Yes.
You listed polycystic kidney disease as a potential cause of persisting proteinuria.
Yes.
How about a single cyst?
So single cyst is not a disease per se. So most of us, we're going to have like a cyst in our kidneys. Polycystic kidney disease is different.
Yeah.
So if you are seeing some cyst and then some proteinuria, that needs to be evaluated. I would think that that proteinuria doesn't come from a single cyst, unless there is a rupture after a traumatic event or something like that. The cyst is damaging the interstitium, so you might see it, but not to the level that you're going to be worried about it.
Okay, thanks.
When you make the switch from a thiazide diuretic to a loop diuretic based on chronic kidney disease and how low their GFR is. And then second is opinion on best loop diuretic. I understand there's better evidence now for torsemide compared to Lasix. And then there's also Bumex. If you could kind of talk about maybe the difference between the different loop diuretics.
So regarding diuretics, I use chlorthalidone, has been shown that it's good to control blood pressure. But I can add like a loop diuretic if I'm seeing edema on my patients, because edema will damage the kidneys. There is a concept of venous congestion. So we need to, if we have a peripheral edema, we most likely have venous congestion, which can cause damage to the kidney. So I'm trying to use, on top of that, the loop diuretics. So in some patients, the chlorthalidone just doesn't work, neither controlling blood pressure, neither controlling swelling. So when the eGFR is below 30%, when I started to switch to a loop diuretic. So regarding loops diuretic, I'm still like to use Lasix. I use Bumex when Lasix, if it is oral, theoretically there is less absorption if we have hypoalbuminemia, but higher doses will work. It is, most of the physicians understand Lasix, so that's I just start with Lasix. Then Bumex, I can use Bumex, so there is no preference. The only time that I switch from loops within is when the patient has allergies to sulfa. Then I use ethacrinic acid. But besides that, whatever is comfortable with you, like use that loop diuretic. And if you have any questions, yeah, we can answer directly, like a phone call or anything like that regarding a patient. But trying to avoid leg swelling. Like don't overdoing it. It's not one. So for example, if you start a patient that is chronically on Lasix 20 milligrams per day, and then patient develop more swelling, you can up the dose for a couple of days and then explain to the patient when the swelling comes down, go back to the dose. There is no a one-time dose of Lasix for anybody and for the same patient. It can change. And then you teach to the patient how to check the leg swelling and all other things like worsening dyspnea, but mainly the swelling. So, yeah. Did I answer your question?
I have a question.
Yes.
Yeah. Is there a role, could you go over the role of sodium bicarbonate in protection of renal function and any possible mechanisms for that?
So, sodium bicarbonate?
Yes.
To protect. So studies have shown that acidosis will cause harm to the kidneys. So the kidneys excrete acids. So when there is a kidney dysfunction, when the kidneys start to deteriorate, we start to the patient increase the non-volatile acids in their body. So acidosis can cause damage to all the cells basically. So and to progress to the CKD. So we use sodium bicarbonate. I don't use sodium bicarbonate. I like to use baking soda. Like half of a teaspoon of baking soda is like 3 tablets or 6 or 3 tablets of sodium bicarbonate. So I use baking soda and some patients like it and it's easy. And then I can go from half of a teaspoon to 1 teaspoon, but I treat the metabolic acidosis. As long as, so if the patient has COPD, well, and then you need to, if you see low bicarbonate, ideally you need to confirm with the venous blood gas. Not all the low bicarbonate is metabolic acidosis, and there can be another source. But if it's just pure metabolic acidosis from the kidneys, baking soda or bicarbonate tablets, but I like baking soda. Any other questions?
In type 2 diabetes with a GFR of around 50, not so bad, do you prefer SGLTs or GLP-1s?
SGLT2. So for what? For diabetes or for kidneys? So there are no studies in GLP-1, like we know SGLT2 inhibitors, and it's in proteinuria. So if the patient has diabetes and has proteinuria, or even SGLT2 inhibitors, and there is good data in progression, initially, a lot of physicians get scared because initially, the first couple of weeks, the eGFR is going to drop. We know that with SGLT2 inhibitors, it should drop because there is change in the perfusion in the glomeruli, change in the hemodynamics. But if the studies show that if you continue the medication versus placebo, after 3 years, it's going to outperform the placebo. So even if initially the SGLT2 inhibitor decreases the eGFR, you should continue it. It's gonna protect the kidneys. And if the patient is not on RAS inhibitors or RAS blockade, because of hyperkalemia, you can start the SGLT2 inhibitors to try to protect the kidney. The problem is the cost and then the risk of UTI. So the meta-analysis have shown that it's not so significant, but you need to still tell to the patient there is the risk that because you are urinating glucose and then bacteria and fungal infection. You explain the risk of UTIs when you use SGLT2 inhibitors. Any other questions?